All right. Well, we're going to redo it again. So I want to welcome everybody to our San Antonio Interventional Forum. It's my hope that we can start doing these things in person pretty soon. Again, I want to thank our panelists. I want to thank Brian, thank Jamil and Chad for their support. It's really a great honor and pleasure to have Dr. Basir virtually join us. Dr. Basir has now rapidly become really the expert nationally and internationally in cardiogenic shock and mechanical circulatory support. He did his cardiology fellowship at Henry Ford, interventional fellowship there, and currently is the director of STEMI and director of acute mechanical circulatory support. He has 70 plus publication in his CV, and he's involved in a variety of different clinical trials. So without further ado, Dr. Basir.
And thank you so much for having me. I really appreciate it. It's a huge pleasure to be with your group. I think that what you guys are doing is really going to fundamentally change your communities and the greater San Antonio area. I have a lot of admiration for this group and for everyone who's been involved. You guys have been continuing a lot of support within the studies themselves, and just getting really fantastic results. I hope that everybody is going to continue that passion and continue to kind of push the field forward, get better patient outcomes. But there's really no better group than the group here in San Antonio. I brag about you guys behind your back because of all of the great work that you've done. We've tried in numerous citywide initiatives to try to be able to gather what we've done in Detroit in other cities, breaking down the barriers between competing hospital groups and interventionalists and hospital systems, trying to do what's best for the patient, and really, collectively gathering data and systematically publishing it in a way where everybody gains, the recognition that they rightfully deserve. And so, you guys are really on that path, probably right behind Detroit there. So really just a huge congratulations to what you guys have built. So I'm going to be a little bit more broad with this group than I typically am. We're not going to, start at the fundamentals or the basics. I'm going to get right to the end of NCSI and where we are, and really focus my discussion on where I think we need to move forward, because you guys were early adopters, and I think that there's always a little bit of cleanup that's needed and always people who are getting on board, but that doesn't change the fact that we as leaders within this field have to start looking to the next step and pushing ourselves in that direction. So I have a lot of conflicts with a lot of different companies, and they're listed for you here. So the National Cardiogenic Shock Initiative is really, finalized in January of this year. We were able to recruit over 400 patients into the study. We really set out to compare ourselves to what was already done in a couple of these other randomized control trials that have been done in shock. So really, we looked heavily on the shock trial. We looked heavily on the intra-aortic balloon pump shock trial, both of which had already been published. And we used a lot of that same background in terms of the case report form, the definitions, to try to be able to see if this strategy of using Impella and early hemodynamic support with the protocol that you guys are well aware of, whether it was associated with better outcomes to really further study this in a more academic way in a randomized control trial. And so, as you all know, it's prospective, non-randomized, single arm, but multi-centered. And so there's 80 sites all across the country, including sites in San Antonio, that have participated in this. And when we excluded patients for the same reasons that they were excluded before, right? So they were either non-AMI shock, they had balloon pump, they were transferred from an outside hospital a couple of days after their presentation, they had unwitnessed arrest, or they had an arrest longer than 30 minutes. Those were all really important things that we excluded patients for. And then the regular stuff as it relates to contraindications to hemodynamic support. I think it's really, really important to emphasize that this was really one of the most sick trials as it relates to cardiogenic shock. So we use the standard definitions which have been available over the course of the last 20 years, but to put them into today's perspective, this is really class C, D, and E shock. And I would argue that the majority of patients are actually in stage D shock, but the line between stage C and D in the current SCAI classification system is really just about that initial therapy and whether there's a response to that initial therapy. So proving that in a very short amount of time is a little bit actually difficult from a trial standpoint. So as we've been redoing the SCAI shock classification, which will be kind of published or discussed at TCT in a couple of weeks, there's going to be a little bit of a nuance here that most patients are in D, but that C to D, is really hard to differentiate in a study, but it's clearly not a pre-shock population. And in fact, 25% of the people within the NCSI are in stage E shock. And the way that we defined it was using the most strict criteria that we could. So active CPR at the time of MCS insertion, a lactate greater than 10 with peri-procedural cardiac arrest, and a lactate greater than 5 to 10, but we only use this definition if they were on multiple high-dose pressors, or they had basically just arrested and were getting like boluses, 0.5 milligram of epi on their way to the cath lab. So really, this is not a lactate of 7 on 2 drips. It's not that patient. It's really multiple high-dose pressors, peri-procedural arrests. And what's really important to emphasize in this stage E group is that they're not going to be included in any of the future randomized control trials, right? These patients are not going to get consented. They're not going to get randomized. And so it gives us an idea about taking care of these patients in general. So, multiple sites in Texas, you can see the highlights in San Antonio, but 80 sites. And what's critically important to, I think, emphasize here is that we are not talking about some tertiary, academic center only study. We understood from the beginning, and I think it's important for other investigators in shock to do the same, to emphasize that the majority of shock comes to the community and then gets selectively transferred to tertiary care centers. And so if we really want to focus in on improving outcomes, we have to do it within the first line hospitals that these AMIs actually present to. So cath lab capable centers that generally have some level of hemodynamic support. And these are still varying sites and different capabilities that they have, but they're definitely not transplant and LVAD sites as the majority of sites. You guys know the protocol well. We use the protocol every time. We do it systematically so that the cath lab staff know what's going on, so that operators who are newer to either intervention as a field or newer to treating cardiogenic shock or the use of hemodynamic support and their experience is low, that they kind of have a idea of how to take these patients on. And then really the crux of the matter is deciding on whether they need any additional support and how they're doing based on cardiac power output, right atrial pressure, and pulmonary artery pulsatility index. And I think this is really been really useful for people. We're starting to talk the same language, where we're starting to be able to objectively make decisions on these patients. And so it's not that, hey, Bobber thinks this patient is stable because they're on a balloon pump and 10 of levo and 5 of dobutamine, and I don't, I think they're just fine. And then one of my partners coming in and being like, hey, this guy is not fine. 24 hours later, his lactate is climbing, his renal function is poor. Using invasive hemodynamics allows us to be able to make some of these judgment calls a lot earlier on with, again, objective evidence. And using this approach, we've really demonstrated nicely that these patients actually get really good outcomes. And so even this 25% stage E group that are not going to be included in other trials, even including them, we are able to achieve a 30-day survival of over 65%. So we're really, pushing, outcomes much better than what's been previously reported. And this is despite worse hemodynamics than other trials, and very similar amounts of cardiac arrest and lactate levels. And so we're really hopeful that this is the right strategy of treating patients now. And in particular, when you look at who's actually going to be included in a randomized control trial, and you differentiate that group stage C and D shock, you actually see that the 30-day survival here is 77%. And it's actually been mimicked somewhat by other studies as well. People are consistently getting survival rates over 65 to 70% in these stage C and D shock patients, treating them early with hemodynamic support guided by invasive hemodynamics. And so I think this is really prime time, one, to take care of patients this way, and more importantly, or secondly, I shouldn't say less importantly actually, is to do studies and trials using this method to be able to really compare the treatment arm versus standard of care, which is really just vasopressors alone, plus or minus intra-aortic balloon pump. The problem, though, with all of this is that Bill and I's expectations of the shock initiative was not to get a 68% 30-day survival, right? We really consistently want to get an 80+% survival in patients with cardiogenic shock. And so who is it that we really need to care for? So, the vast majority of patients, over 70%, are gonna do really well with an Impella CP guided by invasive hemodynamics, good medical therapy, ICU level care, et cetera, et cetera. There's probably 10% that are gonna pass away no matter what we do, irrespective of how much support we give them, because they're elderly, they have other end organ failure that becomes a problem. They have a secondary cause outside of their cardiogenic shock as well. But there's still a really good portion of patients who are really probably still just being undertreated. And, we can look at this really clearly in the shock initiative early on. Patients whose lactates aren't clearing, patients whose hemodynamics are not getting better, patients who still require vasopressors and inotropes. These are all patients we still need to really be worried about. So we demonstrated nicely in NCSI that it's not just about cardiac power output, but when you look at cardiac power output, when we use vasopressors and inotropes, we're doing that so that we can improve the blood pressure, so we can improve the cardiac output. Well, if you correct for the cardiac output and the blood pressure, irrespective of the underlying cardiac power output, you actually tend to get incremental worse survival with every vasopressor and inotrope that you use. And I'm not anti-vasopressor and inotropes. I use them on every single shock patient. But the reliance on them in the long run is where really we have this detrimental effect. The idea and concept that I'm going to put the patient on some epinephrine, on some dobutamine, on some norepinephrine, and demand more from the heart, even though it's been injured, even though, it suffered a very large myocardial infarction, even though it's not pumping well to the rest of the body, then I'm going to just demand more from the heart, as opposed to resting it with devices. It really is physiologically counterintuitive. The same thing is actually an important point, is that using these hemodynamics, we really need to make sure that when we're talking about treating patients, that we're treating them completely with hemodynamic support. So there is a good 30% of patients that actually develop right ventricular dysfunction. And then within NCSI, those who develop right ventricular dysfunction tend to do worse. They tend to have worse outcomes by about 10%, actually. And so if we talk about trying to break this 80% mark, I think one of the really important ways to treat these patients is to actually use right ventricular support devices. And you can see here that it's this biventricular failure group. The patients who are congested, both in terms of elevated CVP and elevated pulmonary capillary wedge pressures, or LVDPs, these are the patients that tend to actually present in higher stages of shock. Their shock tends to be longer in duration. And at the end of the day, treating with a right-sided device comes with very little negative consequence, right? At the end of the day, you may get a little bit more hemolysis. That's something, anytime you have two pumps more rather than one pump, you're going to get more hemolysis. But you're putting in a device on the venous side. And so you're really, this is not about vascular access complications. If you look at the MOD registry for FDA reported adverse events, you can see that there's very little adverse event rate within the venous system for these devices, whether you're talking about an RP or a tandem heart or any other future device that will come out. These are generally safe devices when they're placed in the venous system. And so the problem is that people are really, really shy to adding right ventricular support. I have a very strong feeling that by just adding right ventricular support in the right patients, those are patients with a right atrial pressure greater than 12 to 15, a PAPI that's less than 1 to 1.2, and patients who are getting suction alarms, for example, on their Impella CP. These are patients you quickly put in a right-sided device, their suction alarms go away, their hemodynamics improve. You don't have to, run the right side at 5 liters. Just, running it between, 3 to 5 liters is very sufficient, and actually decongesting these patients. And decongesting helps the liver, it helps the kidneys, you prevent AKI. And so this is really, I think, one of the crux of how do we improve outcomes further, is just by a simple addition of escalating right-sided support. Now, whenever we talk about escalation, though, we're really talking about understanding invasive hemodynamics. And so one of the things that I think all of us should be really proud about is that we've really started to change this paradigm, right? So pre-escape, there was some use of right heart cath and heart failure. After the escape trial, it really kind of went down, and we can slowly see the slow growth of the use of invasive hemodynamics. And with that, what comes downstream is what's really important, because a right heart cath isn't going to improve survival if you don't interpret that data and do something about it. But what you can see on the right hand side of your screen here is that people are doing something about it. They're escalating them. They're getting them to transplant at LVAD centers more often. Their utilization of more therapies, or the utilization of therapies, is increasing in these patients, and that's why they tend to do better. And if you look at NCSI and you look at all of the patients who passed away, you can see here nicely that the vast majority of patients still die of untreated cardiogenic shock. And that, I think, is sad amongst the group that we've included within NCSI. So we really, really want to make sure that when we say we're treating cardiogenic shock, that we're actually hemodynamically reversing that shock. And you can see on the right-hand side of your screen, over 80% of patients weren't escalated because, again, this has been a 5-year study. Getting people to even think about putting in a hemodynamic support device was hard enough. Letting them, understand those invasive hemodynamics, think about right-sided support, that's really the next step for us. And so NCSI in its current form is actually just being scaled down. So we're actually taking, rather than the 80 sites and the 400 patients, we're actually going to recruit 120 patients consecutively, but at the top 20 sites within NCSI. And I really hope that you all will be part of those sites. Please make sure that you let me know that you're interested in this. But basically the request from the team, from the PI, and then from the groups that are involved in the hospitals that are involved, is that we are going to escalate these patients when hemodynamically driven, or when the hemodynamic needs are there. So when somebody's on more than 1 or 2 inotropes or vasopressors, we're going to sit in the cath lab and we're going to try to wean those off and try to see where we can get our patients where they have a reasonable mean cardiac output and reasonable hemodynamics. If we're not able to wean them off, then we're going to sit there and make a decision for ourselves. If the CPO is less than 0.6 and you're on more than a moderate pressor, then you're in trouble. This patient still has a less than 50% survival. And so we're going to ask you that if your right-sided hemodynamics are poor, then you put a right-sided support in. If your right-sided hemodynamics are fine, then you may need escalation up to a left-sided device. And the escalation specifics can still be tailored to your hospital. People like ECPella, you do ECPella. The right-sided device, most of our sites are going to put in an Impella RP, but pick the device that you want and put it in, and then basically see how the patient does from there. But we're expecting still that the majority of patients are going to do well. Their cardiac power is going to be greater than 0.6, and their survival is going to be greater than 70%. But we're tracking outcomes on all patients in your institutions that present with an AMI cardiogenic shock, and then basically use that data to help kind of continue support this line of care. Because no matter all of the other trials that are coming that I'm going to talk to you about, none of them are going to be done within the next 5 years. We may get danger in about 2 to 3 years, but that's the earliest trial that we're going to potentially get. So I think this is going to fill that gap really nicely and provide us a little bit more information on how important escalation potentially is. Now, going on outside of ceramics, the problem that we also identified in NCSI is that these patients still tend to have a high 1-year mortality, right? And there's one thing to say that, there's still a lot of Detroit patients in this cohort. The patients get aggressive early care in the hospital, but then they're still left to fend for themselves and their community that is taking care of them, and that is, can be challenging, particularly in the poorer areas of Detroit. So what we've noticed is that the 1-year mortality is still kind of edging up. And when you look at even just nationally through the NCDR, we still see that mortality is high, particularly over the first couple of months, but it still remains high over the first year, so that there's continued patients who continue to do poorly. And so we really need a strategy to be able to help these patients not have to fend off long-term heart failure either. So we would imagine that the patients who come in cardiogenic shock acutely actually have the largest infarct sizes. And we know that those patients tend to actually do the poorest as it relates to heart failure outcomes, and then long-term mortality, even within the first 1 year. So Greg Stone published this paper really nicely, showing that the higher the infarct size, the worse the outcomes for these patients. So what tools do we have to be able to decrease that potential burden for these patients? Well, SSO2, supersaturated oxygen, is actually the only thing that is currently FDA approved that has randomized controlled trial data showing that you reduce infarct sizes. And so it delivers hyperbaric oxygen 7 to 10 times what's normal. It's delivered directly through a guide catheter, but it's a JL or JR guide catheter. And what supersaturated oxygen does is it improves microvascular flow, reduces the infarct size, and limits left ventricular remodeling. And I think that's going to have potentially a really, really big impact, right? So when we open up an LAD, for example, and we put in a long stent, we're helping the epicardial blood flow, but that microvascular circulation is still stunned. There's still sluggish blood flow. The capillaries are still vasoconstricted. And so what a technology like supersaturated oxygen does is it dilates those capillaries and improves the motion of the red blood cells. So we actually improve microvascular flow and we actually limit the infarct size. And this has been demonstrated really nicely in an animal model, but more importantly, it's been demonstrated in patients, right? So we have the AMI-HOT 1 and 2 trial, and both of them showed in a randomized controlled trial that supersaturated oxygen was associated with smaller infarct sizes. And so it's an infusion that goes on for just an hour, and the patients get really important long-term benefit when it relates to SSO2. Now, the problem with all of these studies is they talk about infarct size, but they don't actually have the clinical data behind it, like what is the impact of decreasing infarct size in these patients. Now, before I get to what we're going to do, it's really important when we talk about infarct size, we're talking about time as well. So, these are patients who are presenting within 6 hours. They're having just really bad, large myocardial infarctions. And so these are going to be a really nice cohort of patients to study. And we're going to be looking at them in a pilot trial called the ISOSHOCK trial. It's going to be a randomized control trial with 60 patients, 30 in the control, 30 in the treatment. Now, the control in this group is going to be NCSI. So these patients are going to get Impella, they're going to get early revascularization, and then if they are in the treatment arm, you can actually then consent them for SSO2. And I think this is really an important pragmatic trial in the United States because we're going to have issues with consent here. We'll talk a little bit about Recover4 at the end, but the United States is going to have difficulties consenting these patients. And we're not going to really, I don't think, get a good progress with waiver of consents by the FDA. And so what this study allows for is consent can occur until the decision for supersaturated oxygen comes in. So we're really, really excited about the study. We're going to have 15 sites involved in the study. We actually got approval by the FDA for an IDE in April of this year, and our goal is to recruit the first patient in December of this year. So again, another build off of NCSI, which I hope you guys will get involved with, but I really think is going to impact patient care, not just now in the short-term hospital survival, but more importantly, in that 1-year follow-up and as it relates to heart failure outcomes as well. So the last thing that I wanted to share with you guys before we can open up for some just Q&A, and I'm super excited to see everyone's cases as well, is I did want to just mention to you that I am the PI of a study called SafeChip. So this is not shock now anymore. This is a high-risk PCI study. And what we're looking at is a single-arm study recruiting 260 patients using Impella, but with early bird. An early bird is a bleeding detection system. You guys may be familiar with it because the company, I believe, is based out of Houston. So you may have more experience with it than a lot of other people. But we're basically looking for 15 sites who do a lot of high-risk PCI. And what we're asking for is that you use the early bird. And we actually see with, current 2021 vascular access practices, micropuncture, ultrasound, fluoroscopy, all the things you guys already know and do really well, that with the addition of early bird, we're able to get really, really low event rates as it relates to vascular access complications and bleeding. And honestly, our goal is less than 1%. So we're really going to be picky and choosy about the sites and make sure we get the best of the best. But I think your sites are really are the best of the best, and we'd be really welcoming for you to be involved in this study if you're interested. So conclude my talk for today. NCSI is the largest prospective trial done in North America in the past 2 decades as it relates to cardiogenic shock. It's really recruited the sickest patients in cardiogenic shock, including 25% who are in stage E shock. The survival rates are really phenomenal, particularly in those stage C and D shock. The 30-day survival at 77% is something that can't be balked at. I think that as we get greater utilization, as we get greater buy-in to the protocol, particularly as it relates to escalation, and as we demonstrate, hopefully in ceramics, that escalation, particularly with right-sided support, is associated with really good outcomes and low complication rates, that we're going to be able to consistently get survival greater than 80%. And then most importantly, for the non-believers out there in particular, if for those who are unsure of NCSI's single arm trial, then this is going to be the trial. This is going to be the strategy for patients in the Recover 4 trial, which will be a randomized control trial of standard of care with vasopressors and inotropes versus NCSI with hemodynamic support guided by invasive hemodynamics. And Naveen, Greg Stone, Bill, they're going to be the PIs of the study, and we're all going to be cheering them on and recruiting for that study. But again, I'm still a little bit worried about consent, still worried about our recruitment levels in the United States. And more importantly, I think it works already. If my father comes in, I'm not sure I'm not treating him with NCSI. And if I'm not treating my father that way, I'm not sure if I can treat any other patient that way. So we'll all have to come to those individual decisions once the trial is formulated and we know what options we have available to us. But regardless to say, I think we've made a lot of progress, and I'm looking forward to working with this group more so that we can continue to do that. So that's it for me. I've talked way too much. I'm so sorry. I'm going to stop sharing my screen and love to interact with you guys.
Thank you, Dr. Basir. That was wonderful talk. I really appreciate all the cutting edge insights and the upcoming clinical trials. I think for many of us, that was really insightful. We already have a couple of questions, and so if the participants want to ask additional questions, they can use the raise hand feature. The first question is, can you define low, moderate, and higher dose pressors?
Yeah, there's a nice, academically, we can use the vasoactive score, which basically will look at the specific dosing of all pressors, and then you can cumulatively come up with a score and then kind of go from there. Realistically, for me, that's anything more than 10 of levofed, right? So 10 of levofed, 5 of dobutamine, 10 of dopamine. These are really, what anything more than that is going to be too much. And I think that, some people like to tincture with their pressors and inotropes. They like to put, like the tiniest dose of epi, tiniest dose of vasopressin and these other things. I mean, if you're on really tiny doses, I don't think that I do what you want to do. But I think when you're requiring vasopressors, I think you still need to be really worried about those patients. And I think if you're on anything more than those moderate doses, you're still potentially in a world of hurt.
Great. The other question here is about surgical disease and shock. So we're often faced with patients who probably would be better off in a controlled setting getting coronary artery bypass grafting, but they're now in shock. What's your approach? Do you put a support device in and then just treat whatever you can? Do you go to urgent emergent CABG? What's the practice at your center?
Yeah, I'm so biased on this. All right. So I consider myself a very, very well-equipped interventional cardiologist. Cal taught me CTOs here. I did my chip year here. I do a lot of complex PCI. I don't think there's anything that we can't do percutaneously that can be done surgically. So I think when somebody comes in shock, my threshold for sending them for surgery is extremely high. And my surgical colleagues have agreed with us. We've had really poor outcomes taking these patients, to the operating rooms early on. That being said, though, I really think it's important to do this with a good, conscious, logical way, right? If we're talking about mostly AMI patients and mostly STEMI, I'm not sure I'm going to balloon something open and then leave it for the surgeons. I think there's still a high rate of that artery closing up. My surgeons are not taking that patient within 24 hours. So for me, I'm left on my island and I'm very comfortable with it. I'm going to revascularize them, culprit only initially, most likely. I would treat a non-culprit if I think it's a dual culprit or encompasses a large area of myocardium, because I'm supported. And, that's our general strategy. I do not think that it's wrong in any program to send patients to surgery. They get put on cardiopulmonary bypass. They potentially get a support device in the operating room and go from there. But logistically, how are you going to do that? If it takes your OR even 4 hours to get ready, then you at least have to support them. But most places, I don't think you're going to get too many surgeons taking patients within 24 hours.
No, I would agree with a lot of those points. Okay, so two questions here from our fellows. One question is right ventricular stroke work index. What's the role of sort of additional indices for RV function? We look at PAPI basically, but are there other things we need to be looking at?
Yeah, so when we came out with the whole system of NCSI, it was never intended for anyone to look at one number, right? I think if anyone has taken away what we've done in the last 5 years to just CPO or just Impella or just RV or PAPI or any one thing, then really it's a disservice to what Bill and I have done, because really this was a strategy and people use this strategy differently, right? So at Ford, we had 10 interventionalists, all who do shock, 4 cardiac transplant surgeons who all put in VADs and transplants, and an advanced heart failure team. We didn't need a 1-800 shock number, right? But we needed everyone to do the same thing and escalate in the same way and use the same objective measures to improve our outcomes. And so we built NCSI with that mindset, and we asked our neighboring hospitals, and they had the same kind of infrastructure as we did in a lot of ways. Now, Alex took that and Benham took that, and they had 40 interventionalists there, right? And they took all of that work and said, listen, we can't have 40 people doing this. It's too difficult. We really need a shock team to be able to kind of organize this and get better outcomes in that way. So it's a long way of saying it's never one thing. These are tools to be able to get patients out of shock, and then to kind of do what's right for them. So I look at everything. I look at the echo. I look at right atrial pressure as my first marker. If it's less than 12, I don't even think about RV support. If it's more than 12 to 15, I start thinking about it. I look at a PAPI. Acutely, if it's less than 1, now this is another red flag for me. The closer it is to being below than 1, again, there's no magic number. This is a linear number, right? So 2 is better than 1.5, which is better than 1. And then, I think that's enough information, but I have the data on right ventricular stroke work index. I know that a level greater than 300 is associated with worse outcomes. A level less than 150 is really severe and is associated with worse outcomes. But how many people know off the top of their head how to calculate a right ventricular stroke work index at 2 a.m. after a STEMI, right? And that's where we have to be logical about what things are easy for people. The pulmonary pulsatility index is just a really simple and easy calculation. Your systolic minus your diastolic divided by your right atrial pressure. So it was easy for people to understand and pick up. And so that's where it kind of stemmed from. But use all of these tools to be able to get to the right clinical decision for your patient.
So, Robert, I'm going to have you answer a few questions on the side in chat, because I really want to get to our panelists and cases before you have to go. There's some interesting questions being posed in the chat.
Yeah, no worries. I'll take a look.
I'm going to pivot to our panelists. So we have 3 folks here today on our panel. Dr. Alan Anderson, who's our Chief of Cardiology at UT Health San Antonio and the Director of our Heart Failure Program. Dr. Nandish Tukral, who is the Director of the Cath Lab at Maine Methodist, and Dr. Murali Senapathy, who's an interventional cardiologist working primarily out of the Christus system. So I want to thank our panelists for being here. And I'm going to actually pivot it over to Brian, who's going to tee up the cases for today.
All right, can people hear me? I am not getting a share screen icon yet.
We're going to send that over to you here in a second.
Okay.
It should be available at the bottom now.
Okay. I'm not seeing it here. Let me escape back to the Zoom meeting. Where are you at here? Okay. So, okay, here we go. Share screen. Got that one. Share.
Perfect. We see it.
Great. Audio's okay.
Yep. He's in Slack.
Okay, great. Well, I have the great fortune of actually tag teaming this this case with Dr. Funamoto, so I'm very grateful for that. And this is a case that I'm sure will Dr. Babar would have done multi-vessel intervention, but we'll see what he says about it. All right, I had this gentleman come in, very interesting. His name is Mr. Owen. He's a 67-year-old man who had no established coronary disease, but really hadn't been seeing physicians very regularly until recently. And he had lost his wife about 6 months prior to this. He was diagnosed with chronic kidney disease and a possible renal mass that they were working up. He presents with 3 days of waxing and waning chest pain associated with fatigue, dyspnea, exertion, and shortness of breath, and came to a freestanding ER where they felt he might be having a STEMI. So they woke me up and sent me an EKG, and he had diffuse sort of ST depression. He was pain-free at the time, but no evidence of STEMI. At that facility, his troponin I was 60. And then we asked that he be transferred to our facility for higher level care. I asked that he be heparinized. He refused that overnight. And his first set of labs that I was able to see the next morning was a BNP of 21,931, a troponin I of 31.5, and a creatinine of 2.2 with an unknown baseline at that time. He was sitting bolt upright on his bed. And when I went to talk to him about catheterization, and here's the EKG they had sent me in the night. So clearly no evidence of STEMI, a little bit of a non-specific conduction delay and some ST depression. And here's the film, the first shots I got. And the first thing I said was, oh boy. So he is he's pale, he's diaphoretic, he's short of breath now. I always, when I do my cases, I start by shooting groin shot to make sure I'm not in trouble. I always do the EDP first. His EDP was 39. And then I took the angio to decide what I was going to do with this guy, knowing that I was going towards mechanical support. His oxygen requirement was starting to go up at this point too. Let me just show you his right, just for completeness here. So I am not as brave as Dr. Basir, so I was not, I didn't know what the culprit was, tell you the honest truth. And I was very worried about tearing something. I had a guy who's pain-free, but he's in shock. He's going into shock. So the next thing I did was I did a right heart catheterization on him. And he developed flash pulmonary edema where we were preparing to do that. We intubated him in the lab. I placed an Impella CP at this point before I even had the right heart data, and asked for a surgical consultation. Here's his right heart. At the time, I just had placed the CP. And it doesn't look horrible, but it doesn't look great. The EDP was particularly concerning to me. His CPO was calculated at 0.85 and a PAPI at 1.64. And I had a mean pressure at this point of 100, but that didn't stay there for very long on the Impella support. We were able to get the patient up to the unit. We did watch him about 30 minutes in the cath lab to see if he was going to need any further support. We got him up to the unit off pressors, and the next morning his Bensons were fairly minimal. The surgeon at that point had a chance to see him, and our echo showed an ejection fraction of 19%, a large pleural effusion, and our numbers the next morning on the support of P8, we had a 3.1 liter per minute. We had no hemolysis, no suction alarms overnight, and you can see now we've got a cardiac output of 3.0 with a CPO of 0.66, a PAPI of 2.67, and an SVR of 2480. And we're just moving the wrong direction. Now, we don't have a 5.5 system at our system right now, but we're 2.5 miles from the main Methodist. So I engaged the high-risk surgery and advanced heart failure team to discuss the case. And we all felt that the patient was going to need acceleration of his mechanical support first to decrease myocardial oxygen demand. We also felt that there was a good chance that if he did not, he needed at least a 5.5 going into the operating room and potentially ECMO coming out. So I was able to speak with Dr. Funamoto and Dr. Ono about him, and they agreed to accept the patient and transfer. He was then transferred to the main Methodist for a 5.5 upgrade and high-risk surgery. And there you go. Anata Noban.
Thank you, Dr. Marek. And I'm gonna take over the case presentation from.
Stop sharing. There you go. It's all yours.
Share. Can you see my presentation?
Now we see it.
There we go.
Can you see?
Yes, we see it.
Okay. And so thank you very much for the opportunity to present my case. I'm a Masaki Yunamoto cardiac thoracic surgeon and newly joined in the team here in the heart failure team in Methodist San Antonio. And I'm gonna show the case after the transfer to the Methodist main hospital. I have nothing to disclose. And in addition to the preoperative information from Dr. Marek, I'm gonna show you the preoperative TEE, so the visual. You can see the LVEF is a visually 50% to 20%, and then It's a little bit system issue. The apex is not moving and the lateral wall is not moving. So it's not moving, sorry. Now I'm gonna move to the preoperative evaluation. And then we evaluated this case. It was a surgical revascularization. And then he was 66 years and with a history of hypertension, hyperlipidemia, and the baseline creatinine is at the time of surgery 1.9. And he is a STEMI, 3-vessel coronary artery disease, and a cardiogenic shock, and pre-op impeller CP supported, and he looks acute on chronic heart failure with LVEF at 90%. And then this is urgent status. So I calculated the SDS score. The risk of mortality was 40%. And then morbidity and mortality was more than 50%. It's apparently the high-risk case. And then for this kind of high-risk case, and then we made a plan for the case going to be supported by the Impel 5.5 and protected and coronary artery bypass grafting. And then we also considered exit strategy of the patient. And he is actually marginal case and to consider for the both heart transplant LVAD option. So we discussed with the family about the possible no exit and a possible potentially could be a candidate for the LVAD in before so taking him down to the OR. In terms of intraoperative course, and he underwent the urgent CABG with actual Impel 5.5 at the same time. And we took him down to the OR on the morning, the day of admission. And after the additional sedation and prep and drape and additional line placed, and I made actually incision and then expose the axillary artery, putting a 1 millimeter chimney graft on the axillary artery, and then placed advanced 0.018 impeller guide wire through the chimney graft and down to the LV, and using a pigtail, and then moved to the sternotomy. I took a lemur down and the SBZ is harvested from leg after giving a systemic heparinization, and cardiopulmonary bypass was commenced with a central cannulation. And then after the starting a cardiopulmonary bypass, I pulled back the groin impeller down to the descending aorta. And on this cardiopulmonary bypass, I assessed the bypass target. LAD and RCA is a reasonable target. However, PDA and PL branch has a small caliber, and then OM branch is small and very diseased, so not feasible and a bypass target. And then so he is just benefit and from so decent target LAD and RCA, and then he has a good collateral from high lateral branch to the distal OM. So we selected the LAD and the distal RCA as a bypass target. And then CABG anastomosis was performed under the arrested heart and it was cross clamp. And then after releasing the cross clamp and the Impel 5.5 was advanced and placed through the axillary graft, and we actually weaned very easily off the cardiopulmonary bypass with the Impella 5.5 support. And glowing Impella was then removed with a park growth, and the total cardiopulmonary bypass time was 68 minutes, and the total cross-clamp time was 49 minutes. And then Impella's flow was around 4 liter on P8 of the Impella 5.5 at the time to leave OR. So the image at the right side or bedside TTE right after the surgery. And then, so we always order the TTE at the time of the ICU admission, and it confirms the Impella position. And then this case, it's actually a little bit difficult to place the Impella. So actually the Impella CP is also a little bit challenging to have a good position. You can see the a little bit protruding the interventricular septum and pushing toward the posterior wall. So usually the Impella device with a pigtail is a little bit difficult for this kind of anatomy because you manipulate and a lot your pigtail could catch the mitral apparatus. But for the Impella 5.5 does not have pigtail, it's we could obtain a good position and with a TTE guidance. And then we also make sure the apical four chamber view, and in addition to the parasternal long axis. And sometimes if you see the good position is a parasternal view, however, the tip of the Impella pump is pushing towards the septum and having a trouble in the apex view. So the strongly recommend the two view and to confirm the Impella position is appropriate. And especially the Impella 5.5 is easy to adjust the position. So we always check the two view and the Impella 5.5 position. And then in terms of post-operative course, and he got extubated day 1, and then we weaned the Impella and within a couple of days, and then down to the P4, and then we weaned the epi and optimize the volume status and have a patient out of the bed and let him ambulate on the low-grade Impella support, and then to optimize the patient condition. And then actually Impella was removed at the bedside at the local anesthesia in the day 6. And the epi was weaned off the next day, and then he has a remaining the heart failure. So we weaned the dobutamine off slowly and with volume optimization. And then he eventually transferred the rehab unit and day 14 as initiation of the GDMT. So this is a post-operative TTE, and is still not the normal LV, but LVESs are coming back to the 30%-ish. And the wall thickening is recovering the apex and anterior wall as well. So I want to talk a little bit about the high-risk cardiac surgery like this case. And then to perform the high-risk cases, and we need to think about these factors. So how to identify the high-risk cohort and how to plan for the perioperative management and to avoid a negative spiral post-cardiac shock leading to the multi-organ failure. And then exit strategy. As everyone knows, STS Euro score is very useful tool for risk prediction. And the cardiogenic shock, low EF, and end organ dysfunction, case complexity are the factors for high risk. And then in most of the cases, the key of the post-operative management in high-risk surgery is how to get through the very acute phase right after the surgery with a good condition. So capability of the tailored MCS approach and its infrastructure is crucial to deal with this kind of surgical high-risk cases. And then appropriate planning for the perioperative management is also mandatory for the high-risk cardiac surgery. And in this case, we selected protected cardiac surgery as impelled pipeline support. And you also need to consider the potential exit strategy, like a bad and heart transplant. And then you should discuss with the patient and the family in advance if the patient deemed as a reasonable candidate for any advanced heart failure therapy. And at last, I would like to briefly introduce our advanced heart failure program. And for last 1 year, we are number 3 in heart transplant cases volume in Texas, and number 1 case volume of a surgical impeller insertion in Texas, and then number 1 case volume of the ECMO in Texas. And as you see, we are the one of the leading advanced heart failure program in entire Texas. And this is a heart transplant case volume. We are number 3 after the Houston Methodist and UT Southwestern Dallas. And this is only the San Antonio cases, but we are doing majority of the surgical in the 5.5. And then, so we did more than 180 as a ECMO cases last year. And then we have already done 100 cases as of August. So to deal with the high risk cases, MCS is a very strong management tool for heart and lung support. However, the MCS is not just a one-time procedure, so only a team with a robust MCS experience could provide optimal MCS strategy tailored for patient status and a maximum survival benefit. So we are the only program to have a comprehensive MCS and a transplant and VAD option in San Antonio. So please feel free to call us if you have any concern of your patient. Thank you.
Thank you, Dr. Funamoto and Dr. Malik. It's a really interesting case. I want to give our panelists a chance to share their perspectives. So let's start with Dr. Anderson. This is a case of someone who develops worsening acute heart failure, and the decision has to be made of escalation of hemodynamic support and bypass surgery, or potentially even try percutaneous therapy early on.
Hi, guys. Welcome. No, I mean, I think this is a great case. It really demonstrates what is contemporary management of this type of cardiogenic shock patient all the way through to the end. And it's at every point along the way, it's important to have a strategy and important to have a bailout strategy as well. A couple of interesting things about this case that I think are noteworthy. One, he had as much blood pressure as he did to begin with. That was actually probably a good sign that you might have a chance, as opposed to a person who comes in like this with a map of 40. I think the other interesting thing is ventricle was really dilated early on. And so you certainly gave you the impression that there was a chronic component to his ventricular dysfunction. But I'm a big fan of the axillary impella. I think that's the way to do it. You probably got this guy extubated, what, on post-op day number 1, post-op day number 2. So you could really begin to move him around and save him the morbidity and mortality of just being in the ICU, right? And so that axillary impella gives you tremendous latitude to be able to do that. That's certainly our favorite approach as well. It's very stable too, and they can move around. So one of the really interesting things, and Dr. Basir mentioned this early on, is sort of how will this guy do long term? And I think that's always an interesting question. He has survived, and that's a huge accomplishment. Will he survive and be a class 2 patient on best guideline directed medical therapy, or will he survive and be a class 4 patient? But you can't be a long-term survivor without being a short-term survivor.
Thank you. Dr. Tukral, your approach as an interventionalist to this case, would you have attempted percutaneous therapy?
Tough question. I think I probably would have made an attempt. I think the guy seemed reasonably stable at that time to make an attempt, but these guys are only stable until they're not. And then, you sometimes kick yourself for taking a stable situation and turning it into an unstable situation. It looked like there may have been an antegrade channel in some of those vessels, so they may, relatively crossable at the time. So certainly if I'd run into any problems, I probably would have bailed out an MCS in and probably gone down a surgical pathway. I think part of it depends on the surgical availability. Not every surgeon's going to be willing to take a case like this to the operating room with a patient, in pre-shock. So I think that's the other factor to take into account.
Well, to your point, Dr. Senapathy or Dr. Basir, either one of you or anybody on the call, would you think trying to probe at it with a wire, if it crosses easily, keep going or stay away from it?
Great case. Looking at the angio, I really felt that LAD had a lot of subtotal, occlusion, and it would be easy to cross with a wire. I will have to take a look at the angio again. I would have never thought a surgeon would have actually taken somebody like this for bypass. To be honest, I'm kind of surprised, and it was a good outcome, But I personally would have really tried that LAD, and to me, the circ also seemed to be a doable option. The RCO seemed to be more like a CTO with bridging collaterals. I probably would have saved it for another day. That would have been my approach. But obviously, I think Dr. Malik obviously had, this association with the surgical program, which is always an advantage. But I think in these cases, it's always, what do you do? I mean, you could do it and everything goes well, but also you could get into trouble. I mean, this can happen with PCI, it could happen with bypass. So I think it really depends on the setup and the support you have.
As the one guy here who doesn't do surgery or intervention, but is a heart failure transplant guy, I think one of the really smart things about the decision making here was whether or not to do that, because if you do intervene and you're somewhat successful, and then you commit this person to DAPT, they've got antiplatelet therapy, and then they don't do well, then your surgeon has now got a case. On top of all of this, they're likely going to bleed like stink. And the perioperative period, he's a virgin chest, but if you got to do a VAD, if you got to do those things, they'll bleed from everywhere. And so it does, if you've got the surgeon that has the chops to do it, then it does make that person's job harder for what that's worth.
Dr. Carpenter's on to that point. Maybe we can get her perspective as well.
Yeah, Brian just appealed to me to comment. I think that it needs to be a joint decision between the guy in the cath lab and the surgeon, but it's very reasonable, particularly in patients who are otherwise relatively young and pretty viable, to take these cases to the OR. I've been impressed by a couple of the 5.5 cases we've taken In fact, we've got one getting ready to go home this week that that I was pretty sure was dead in the OR. So it's worth a discussion, and there are surgeons who can and will do it, and you just have to look at what your situation is at that moment. The discussion needs to be happening pretty quick, and you make a decision, and you don't get to change your mind later.
My biggest concern,
It can be a real bleeding nightmare, but worse things can happen.
yeah, my biggest concern was not providing him the best complete revascularization.
And that certainly is typically the big advantage to a surgical revascularization. That you can get to some things that you may not be able to get to, or you can do everything at once instead of needing to stage things because you've got somebody who's pretty sick and you want to deal with a culprit vessel and come back to live and fight another day. But I certainly can't criticize any surgeon who would say no to that case.
The other thing is, I think the idea of just going to support, right? Anyone who thought that they were going to come out of the OR without any support would have been delusional.
Oh, yeah.
And so, you're part of your operative plan is, okay, this person is going to get serious support for, this is not a balloon pump case. This is not a CP case. This is a 5-5 case, and, with preparation to escalate up if you needed to. So, I mean, I think that's the other thing. This is not a multi-high dose pressor case either. They might need it acutely, but you want to get them off all of that stuff. You need to rest that unloaded ventricle for a while.
This guy we're sending home this week, sorry for the squeaking dog in the background, came to us advertised as a 25% EF from St. Elsewhere, and by the time he actually got to us, had a 15% EF, and coming off pump looked like about a 3% EF. We put the 5-5 in, I'd like to say expeditiously. We had a real challenge getting across the valve, and I was not at all embarrassed to call Dr. Prasad to come down and help with that. But we rested that heart for 6 days. Don't want to be in too big a rush to come off. And he came off the device support. Because he weighed over 400 pounds, he had other issues that kept him in the hospital, but he's now 28 days post-op, and he'll be home by Friday. Home, not nursing home, not rehab.
Thank you, Dr. Carpenter. Dr. Basir, before we move to the next case, your thoughts on this case that Dr. Malik presented?
It just goes to show you what we're capable of. I mean, this was a fantastic case. I think just by the book, everyone made great decisions. Patient wasn't loaded with an antiplatelet agent, was able to get to the operating room quickly, got early support in the cath lab to be able to buy time to get to the operating room, was upgraded, and then subsequently not treated with high dose vasopressors and just like Dr. Anderson mentioned, and came out unloaded and then subsequently weaned off. I mean, it's just textbook. I applaud you all. Few hospitals can do it, and that goes a long way into your surgical program and the kind of work that you all are doing. So fantastic.
Thank you.
Dr. Senapati?
Can I ask a couple of questions? Okay. So, I want to get, everybody's thoughts here on loading with dual antiplatelet therapy. So initially, our practice was anybody even with unstable angina, non-STEMI, who comes in the ER, we would load them with dual antiplatelet therapy and kind of worry about the, other things later. That's one question. And the other question is, this guy, even from what I can remember from the presentation, seems like more of a chronic, thing that deteriorated. Could you put him on a support with 5.5 and, sit on him for a couple of days let him recover, and kind of, then decide what you guys wanted to do? Would that be a reasonable approach?
That is also a reasonable approach, I think. And then, so we are discussed about just place impeller 5.5 and then buy some time, but so he didn't get the antiplatelet therapy, and then we thought that it's a reasonable timing to revascularization at the same time. So, but as you said, is the impeller 5.5 and the bridging is one of the options.
Yeah, my preference on these guys is what I'll do is if I have to intervene and then send to surgery, I'll put them on Cangular until about an hour before the surgery and then shut it off. And that's worked very well for me.
I can't say that I have found it quite so great. But it's better than 600 milligrams of Plavix or Brilinta.
All right, guys, we need to move on to the next presentation here. I think Dr. Nguyen is up next. So thank you for that interesting discussion.
Can you hear us?
Yeah, we can hear you.
Which one was it? Getting ready to share.
Okay, can everybody hear me? Yeah. We good? Okay. So thank you everybody for this opportunity to present this case. This was during the pandemic time, of course. I have a case presentation on a COVID myocarditis who came in with biventricular failure. How do you go next? Okay. So I have a 32-year-old gentleman, no previous medical history. Came to the hospital with shortness of breath, nausea, and vomiting for about a week. He was diagnosed with COVID-19 and he was admitted to the hospital. On day 2 of hospitalization, he developed hypertension and respiratory distress. Rapid response was called. Patient was then transferred to the ICU. His initial echocardiogram during his hospitalization, his EF was about 35 to 40%. I was asked to see him urgently because of the shock. On examination, when we saw him, his heart rate was at 130, his blood pressure was 80/46. He was setting 96% on a non-rebreather. The intensivist placed him on dobutamine, knowing his echo. Patient was also placed on Levophed too as well. I interviewed him. He was awake but confused, very tachycardic. Lungs had some rales. He was cold and clammy. So at this point, he was intubated by the intensivist. This is his laboratory findings. Troponin is 15.8 with a creatinine of 2.1. White count is 12. Lactic acid level was 3.8. His after intubation, his blood gas, a pH of 7.227, PCO2 of 38, PO2 of 313. He's on FiO2 of 100% with a PEEP of 5. His EKG shows sinus tachycardia with an incomplete right bundle branch block, and chest X-ray show mild congestion with cardiomegaly. So this is his echocardiogram on the day of when I saw him in the ICU. You can see both chambers are dilated, biventricular failure. He's at this point, we took him to the cath lab. Because of the elevated troponin, we did a coronary angiogram. I took about 3 shots to make sure that he doesn't have any significant coronary disease. His arteries are unremarkable. So at this point, he's in shock. He's on levo. He's on dobutamine. We went ahead and put a CP impeller in. We got a cardiac output of 3.8 liter per minute. Even after the impeller, his pressures were still in the 70s and 80s. We added neosynephrine, and his pressure got better a little bit with more vasopressor. And then we did a right heart catheterization. his wedge was 25, his RA pressure was 26, and we got a PAPI score of 0.5. And at this point, we decided to put a right-sided impella in, and we slowly titrate up the RP to kind of give the same output between both the right and the left. We got a 3.5 liter on the right side and a 3.8 on the left side. So our initial map on the CP only was in the low 50s, and after we initiated the bipella, the map went up to 60s. A Swan was placed into for continuous monitoring. It was then transferred to the ICU. So, when the day of implantation, he was on neo, basal. He was on neo, levofed, and dobutamine. The second day of the implantation, this is the impella, the bipella. Second day of implantation, he was off of neosynephrine. He was on a little bit of levo for a few more days. His kidney function improved. He never required dialysis. We did initiate IV steroid. And on day 5 of bipella implant, we did a repeat echo. His RV and LV function improved. And on day 7, post implantation, the bipella was explanted. Patient was extubated. His kidney recovered, and he was discharged home. This is the echo. This is 5 days after the impella was placed. You can see both right and left side chambers are improved. We were able to, get him off of pressures quickly with the mechanical support. So in summary, this patient with myocarditis and biventricular failure, we were able to manage him with mechanical support effectively, and reducing the number of pressures, which prevent irreversible end organ damage for this patient. And this is his echo before he was discharged. And his birthday was 2 days, 2 days after we placed the impella in. So I'm glad he went home and survived. Got 2 little girls at home. Any questions?
Thank you, Dr. Nguyen. For our panelists, anybody want to chime in? We've seen quite a few dramatic COVID cases, and obviously myocarditis is one that often requires, hemodynamic support.
Yeah, this is Chandra Kanavaripu. Can you hear me?
Yes.
Great case, Keith. It's amazing what you did. Well, like you rightly pointed out, these myocarditis, especially pulmonary myocarditis, they go into severe BIV failure, and you immediately went into the RVAT support, which is excellent. We see the same thing here. You have to have a low suspicion to go to the right-sided support, and it really worked out well. Excellent, and congratulations, you saved this patient's life. And one quick comment, it's one thing we want to say is shock is a spectrum, like these 2 cases were presented. It's so hard to know when to intervene, what device to use. The first one was an Impella 5.5. This one was a BioVAD. Then there is an ECMO strategy. How do we really escalate? When do we escalate really matters. Hopefully the clinical trials will help us to understand how we create algorithms and all. But, the shock board really helps us to increase the awareness quickly and save these patients' life, I think. And both the cases demonstrated how well we performed here. That's my comment. Thank you.
Thank you, Dr. Anderson or Dr. Basir, Dr. Tukral, any comments?
I think one of the things that's really important to remember about myocarditis is, as remarkable as it is, the people who often have the most fulminant courses are often the ones that are most salvageable. And so this kind of strategy for this type of patient really is life-saving. I mean, this person would have died 4 or 5 days on support, and his long-term prognosis is actually probably pretty darn good. He will probably recover from this. We treat these people chronically with GDMT, but it's unclear whether they all need that or not. But it really is a quick on, quick off kind of disease process. And when you treat with steroids, I presume you treated high dose steroids as though you were treating myocarditis. Was that what you did, like methylpred 500 or 1,000 or something like that for a few days?
We gave actually 40 milligrams IV prednisone, BID.
Oh, so you gave pretty small dose prednisone.
Yeah, I mean, I left it up to the intensivist and the infectious disease doctor to treat COVID. I mean, the data for myocarditis treatment is not that great. So, but he was improving on 40 BID. Yeah.
I think the key point here is you didn't have horrible COVID pneumonia and ARDS, and oxygenation was never an issue for you, right? So I think that's that was obviously in favor of this patient.
Correct.
I think one quick comment here is, like Dr. Anderson mentioned, it's a matter of unloading the heart and resting the heart. That's the key. And second thing is figuring out what anti-inflammatory therapies to give. Obviously, we don't have much data to support, all these anti-inflammatory therapies in an acute situation. Sometimes you can use IVIG. I'd like to hear what Dr. Anderson says on that. But yeah.
This is a fascinating area. It really is. And we really have no idea what to do. And it's not clear. It's very hard to stand at the bedside in a patient like this and do nothing, even though that might actually be a totally acceptable therapy. IVIG therapy, certainly in kids, there's some data for it. There was never great data for adults and an unselected population. But the flip side of it is the downside to IVIG is virtually nothing. And so using that as an adjunctive therapy in this population, I think is a very reasonable consideration, again, in the absence of significant data. I think the other thing is this is a person, you knew what the diagnosis was. You didn't need a biopsy. You didn't need those sorts of things. I think it was very reasonable that you knew what your diagnosis was and you went with it. Did the person have really low voltage on their EKG, just out of curiosity? That's the other thing. There's a lot of myocardial edema, so you think the walls are thick, but what you're really dealing with is acute myocardial edema from the inflammation.
The voltages were fine. I didn't see any, there wasn't any low voltage.
Yeah.
All right. We're going to pivot now to the last case. Dr. Cahill, if you want to start pulling up your slides.
All right, well, thank you. I have a presentation from Brooke Army Medical Center on, this is basically a mixed shock case. We had a U.S. Army retired 68-year-old man with multiple medical problems, including known situs inversus totalis, prior PCI to his RCA in 2001. He had diabetes, hypertension, hyperlipidemia, some chronic kidney disease, alcoholic cirrhosis, and peripheral artery disease with prior left fempop bypass in 2011. He presented to our ER with chest pain, shortness of breath, and hypotension. EKG was obtained on arrival, and I'll show you that in a minute. Just filling in some other his past medical history. Again, he also had some bilateral iliac stenting and even some stents in his SFA and below. His medications, he was on triple therapy with aspirin, Plavix, and rivaroxaban at that very low dose. Protonics, insulin, and lisinopril. His family history, he had a brother who died of alcoholic cirrhosis. He was a 100-pack-year smoker and former alcohol abuse, but he quit both, denied any illicit drug use. His exam in the ED on arrival, his blood pressure was low, 74/44, MAPA 54, heart rate's 100. He was tachypnic and he was satting 100% on 3 liters. He appeared anxious, moderate distress, and was confused. He had some JVD, tachycardic, but normal heart sounds and no murmurs, some crackles in his bases, and he had pale, cool extremities and weak distal pulses. So this is his EKG that was obtained in the ED. And so this was also done with the precordial leads across the right side of his heart once we got the history of the dextrocardia. You can see I felt as though there were ST elevations in 1. In AVL, there were 1 millimeter, along with the profound ST depressions, V4, V5, V6. And this is a comparison of a prior EKG about a year prior to his presentation, more consistent and done with the usual precordial leads along the left side. So you kind of see the usual R-wave progression for dextrocardia. Anyhow, his labs in the ED are notable for profound anemia, hemoglobin of 5.8. He had some coagulopathy, and his creatinine was 3.82. Cardiac troponin T was elevated and pro-BNP was elevated. This was his chest x-ray in the ED, a chest AP. You can see the dextrocardia and some early pulmonary edema. So in the ED, after the code STEMI or the STEMI was activated, he was loaded with aspirin and Plavix at 0.6. While awaiting the cath lab team, he was tested for COVID and was negative. He was treated for some hypoglycemia, D50, and then he was started getting his 2 units of packed red blood cell transfusion for his anemia. But he got worse in the ED, worsening mental status and increased respiratory effort, despite being upgraded to 15 liters on a non-rebreather mask. And he ultimately had PA arrest 1 hour into the ED. He underwent rapid sequence intubation in the ED, 20 minutes of CPR, and they got ROSC. During the ACLS, there were no shockable rhythms, and a Lucas device was used. And he was started on IV norepinephrine, and that was titrated up to 30 mics per minute. His labs after the code, he got an arterial ABG that showed a lactate of 9. You can see the pH, and he was additionally transfused another 2 units en route to the cath lab. So I decided to take him to the cath lab and see what I could do. So in the cath lab, I'll kind of go over some of the pictures, but in general, he came up with a MAP of 72 on 30 mics of levo, and I measured an LVDP of 35. So maybe we can show some of these pictures. I apologize, the images are kind of jumbled a little bit, transferring from the military system, but I got access on the left side for the Impella, and I'm actually accessing his FEM pop bypass graft right there. You can go to so then I'm doing an aortogram showing that with the pigtail, and there's no aortic dissection. And then I am crossing into the LV with the pigtail and putting in the Impella pre-pictures. And I measured that again, the LVDP was 35 on insertion of the Impella. So there you see a shot of the RCA. To me, it looked possibly acute, but also potentially more chronic. But there is a proximal RCA total occlusion there that's heavily calcified. And then I'm injecting the left side And then, you know, the case is very difficult because everything is opposite, but there are some septal and epicardial collaterals to the RCA there. Next one. This is a nice one right here. You can see here that I did see that there was a severe stenosis in the basically ostial proximal circ, but the LAD looks okay. I should mention bedside echo en route to the cath lab showed an EF around 20%. You can see there are some nice collaterals to the RCA. So show the one where I initially, after putting the Impella, tried to open up the RCA. So I probed it with using an A01 guide, 6 French, a Turnpike LP microcatheter. I tried to run through, then I escalated to a Fielder XTA and the Pilot 200, and I had really no success. And that convinced me that I was dealing with more of a chronic RCA CTO. So then I shifted gears and focused my intervention on the circ. So you can kind of go through, yeah, nice picture of the collaterals. So I ended up ultimately engaging the left coronary with an EBU 4 6 French guide. I put a run through down the LAD and a run through into the circ, and end up doing PCI of the circ with a 2.5 stent, and then ballooning it up to 3.5, and then doing kissing balloon stent angioplasty of the circ. I felt like I got a good result, and so then we transfer the patient to the ICU on Impella, and I can kind of show you some of the final shots here of what we got. And by IVUS, it was well sized after post dilation up to 3.5. We can probably just go to the there's the final some of the final shots. So I felt I got a good result, at least Timmy free flow down the circ and the LAD. So we didn't go back to the presentation. Okay, so again, stented the circ. So I did a right heart cath while I was still in the cath lab after my intervention. This is now on Impella CP at P8, mechanical ventilation with an FiO2 of 100%. So his cardiac index was now 3.7. Also, he's on norepi at 30 mics, 3.7 liters per minute. And my SVR was kind of low, 8.6, PVR 2.2, wedge 31, mean PA 47, RVDP 30, RA 30, and you can see the PA sat, the CPO, and the PAPI. So at this point, I decided that I might need additional right-sided support, but the PAPI was kind of borderline, and I decided to see how he did with more diuresis, more blood, and just continuing some with my inotropes and vasopressors. I did not put in a mechanical right-sided LVAD at this time. So that'd be an interesting thing to talk about if others would do this, if others would have even put in the Impella. But here's his chest x-ray in the ICU, and then his labs in the ICU in the first 24 hours. What really led me to not escalate is that I got rapid improvement in my lactates, and my other hemodynamic parameters started to improve. We cultured him up, he was negative, and his liver didn't ever take a big hit, and his kidney function started to improve, although he did have an AKI. And his echo on hospital day 1, you can see he had severe LV dysfunction, EF 20-25%, akinesis of the inferior wall, some mild to moderate MR, but no significant other valve disease. His RV size was normal with some RV dysfunction with a TAPSE of 1.1. But he did improve with diuresis and basically the Impella CP and some vasopressors. He was ultimately extubated, and the CCU attending at the time decided to transfer him to Methodist, where he did undergo further evaluation. But he did not require any escalation of mechanical support at Methodist. They decided to continue the same plan. And ultimately, his Impella CP was explanted after aggressive diuresis. He was weaned off vasopressors and started on GDMT for HFrEF, and ultimately discharged from the acute rehab facility. And GI workup didn't have any source of bleed, but he wasn't continued on triple therapy, just basically DAPT after PCI. Ultimately, though, he did have more issues with chronic limb-threatening ischemia of that left leg, required a BKA at 4 months post-discharge. But after that, he was doing well, other than now having right lower extremity clonigation at his 1-year follow-up on October 7th. So I am interested if anyone else would have, taken a different course with this case, any other thoughts, but his echo at 3-month follow-up showed he did have improvement of his LV to mid-range around 41 to 51%, and still had some akinesis and wall motion abnormalities, but his RV had improved in RV function, and his IVC was now in normal size. That's all I have for my case. I open up to the panel and any questions.
Dr.
Thank you, Mike,
Cahill,
for a great case. Chandra?
Yeah, just a quick comment. Dr. Cahill, excellent presentation and opening up a good discussion here. Just 2 comments. We under-recognize medical management in right heart failure, and you rightly pointed out, Bumex drip is like a medical RVAD. And you rightly brought it up here before we escalate into mechanical side of it. You always want to optimize the right side as much as you can with the drip and being aggressive with diuresis and all, since you have good blood pressure. Another approach I think we would have done a little differently would be if someone is on CP device through femoral approach for more than a day or 2, we are quick to escalate them to axillary approach, especially in the setting of pulmonary hypertension like that, along with high filling pressures. That gives them more mobility and less chance for lower extremity ischemia and all. That's something we have learned in a bad way too. So that's a comment I think I have. Other than that, you have done an amazing job in treating this patient.
Yeah, I would second that. I think this would be a good case for, it'd be interesting surgically, I'm sure, but since it's reversed. But I think this is a case where maybe a 5.5 would help. There's a question in the chat here. What was the cause for his severe anemia?
We believe it may have been just the triple therapy that he was on. The GI workup didn't reveal anything. I mean, he had underlying cirrhosis, so there's always a possibility that he had bleeding that wasn't found.
For our panelists, would you have approached this case any differently or any comments?
I mean, I think it was a great case. I mean, these kind of cases are challenging at baseline, and then to have the anatomy reversed is, that's just adding insult to injury for the operator. So, kudos to you. To get out of that case, and I think it was the right approach, and if you're not getting anywhere, completely revascularize them as best you can, and get out. So I thought it was a great. Congratulations.
Nandesh, would the FemPop bypass on that side have given you pause for Impella placement?
Yeah, I think it definitely would have given you some, but at that moment, I think you do what you have to. Certainly, I think an axillary approach is a better approach in the long run if it was an elective PCI, or something like that. But in the heat of the moment, unless you're very, very facile with axillary, in a hemodynamic unstable patient, I think I would have done exactly the same thing.
And I couldn't tell. It looked like there was a left iliac stent versus calcium there, right? In the external iliac.
He had left iliac stents, yes.
Yep. So, I mean, it's definitely a challenging, Impella delivery case. Yeah.
One of the interesting hemodynamic things, I'd be interested in Mir's opinion on this as well. This is a great example of why there's not one number that works for the right ventricle. So the things that I saw there that made me think that you would have been okay were the fact that, first of all, you had significant pulmonary hypertension in the setting of all of this. So that's not new, that's chronic. You've got a conditioned right ventricle, and the CVP wasn't that high. And it responded to diuresis. I mean, all of the filling pressures were high and he responded to diuresis. His cardiac output could have been very misleading, right? With him being cirrhotic, his output looked awfully good, but it could have been 7 instead of 15 because of that. So the combination of the pulmonary hypertension here was probably your friend. If the right ventricle had been ischemic, you would have had a lot of problems here. And I think that's when the RV, if this was a ride or you had a problem with right ventricular ischemia, he would have gone down very quickly and would not have tolerated univentricular support for that. So those are just sort of my perceptions, but Mir's probably got some more.
No, I echo the same thing. I actually, that circ, I don't know if that's enough to explain the shock, right? I mean, and interestingly, I think there was like at least a 10-point difference between your SVC and PA SAT as well, which again could be just anomalous pulmonary return from the liver cirrhosis and things like that. I think the right heart cath pre-support would have been really something I would have done just to really get a clear idea exactly what was going on. You do definitely get a false high output and index, but it's still a little puzzling why this patient was in as profound a shock as he was. And I wonder if a lot of that was driven also by just this prolonged PEA arrest. And then all of these hemodynamics are now manifested, just because of that long arrest. And, it's regardless of that, it's a fantastic case. I mean, doing a dextrocardiac case in this setting is difficult as it is. So great save. I'm glad the patient's doing well.
Thank you. Yeah.
All right, Mike, thank you so much. Any other comments? Well, I want to be mindful of everybody's time. I really want to thank all the participants. Dr. Basir, thank you so much for sharing your evening with us and all the panelists. I do want to announce that the next gathering will be on November 4th. Dr. Raj Patel from Oxygen Clinic will be presenting. We're going to try to do this one. It's going to be actually in person. We're going to try to do a hybrid, but at Wildfish. We'll have Brian send out, more information. You can contact him for the details. But again, thank you for everybody for spending your evening with us, and look forward to more of these in the future.
Thank you, guys. Good night, everybody.
Good night.
Thank you, everybody, for a great discussion.